But first, Selinexor is a completely new drugs considering the mechanism of action, XPO1 inhibitor. So I think that at first we have a possibility to switch to a completely different mechanism of action. Currently, we have available a double opportunity to use Selinexor-based treatments in relapsed refractory multiple myeloma. In earlier relapse, we have SVD according to Boston trial, in which Selinexor is combined with bortezomib and dexamethasone, starting from first relapse of disease, and I strongly think that this combination covers an unmet medical need, because particularly in patients with relapse after monoclonal antibody anti-CD38 and immunomodulating agents, so for example after DARRD, I think that Selinexor VD can cover a really important unmet medical need, considering that we have few options in these patients. We have KD, we have PVD, but I think that according to both efficacy and tolerability, SVD, also considering the simple way of administration, the oral administration of Selinexor together with subcutaneous use of bortezomib, I think it can be an incredible opportunity for our relapsed patients. Also because in my clinical experience, in clinical practice, in early relapse, the gastrointestinal disorders in some way discussed with Selinexor in every treated patients are almost absent if the patient is correctly prophylaxed, particularly if from a point of view of gastrointestinal basis we use the correct drug, so the correct administration, not waiting for the problems, but in prophylaxis before that the patients develop toxicity. I think that also in compliance, not only tolerability, this regimen is particularly interesting. The other way of administration which we can use this drug is in every treated patient. We know the STORM trial, so the mono administration, the monotherapy, so only with an oral drug, oral administration, we can in some way treat every treated patients. So someone in which maybe we have failed all the available opportunities, or in which we don't have the possibility to use the available drugs. We know that we are in the immunotherapy world, a new generation of immunotherapy based on bispecific antibodies, CAR-T. Well, we know that the patients are not the same, and we know that some patients, for many point of view, could not be eligible for this treatment. From a logistic point of view, caregiver, comorbidities, and so on. And I think that having a so manageable drug possible to be used also in later line of therapy is another great achievement in myeloma world. And in general, I think that also for patients in which we have totally failed, totally refractory to classical immunotherapy, the idea to switch to another mechanism of action could be an important treatment for this category. I think, and I strongly hope for the future, that we need to understand who is the best responder. So I hope that studying from molecular point of view the patient, their molecular status, we will be able to develop biomarkers that correlate with XPO1 inhibition, because I'm sure that we can optimize this treatment. However, my perception with SVD and as in monotherapy are absolutely good, and I think that we have other very good options to be used for relapsed refractory myeloma, and I strongly hope that in next future, according to the ongoing clinical trial, for example, EMN 29, SPD versus CELO-PD, we will be able to use Selinexor also in other treatment, and I also am really curious to see the evolution of a STOMP trial, because I think that Selinexor will offer the best of this action and of with synergism with new molecules, such as, for example, mezigdomide. And I am particularly curious to see the evolution of this combination with a double oral drug with incredible efficacy and wonderful synergism and mechanism of action. So I think that the best has to come, and in this moment we try to optimize what we have, and I hope that we will be able also to collect real world data about selinexor based treatments. Thank you for your attention.